Right then. So first of all, welcome everyone. Thank you so much for joining. It's lovely to see that there's so many of you here. And we hope that we can provide a really insightful day for you. So today should provide some really exceptional insights into the medical profession. But of course, we are limited with the current pandemic. And so we have to carry this out over Zoom. But it will definitely still be useful for you guys. Can't wait to hear what you think. And last of all, just to introduce the whole of the Medapply team. So my name is Shrey. I'm the co-founder and director of Medapply. I'm joined by Catherine, who's also my co-founder and co-director. Then we also have Varcha, who's our wonderful content manager. So we have Shahir, who's our wonderful content creator. We have Vivek, who's our wonderful content manager again. And Navina, who is our outreach lead, and she's busy putting everything on YouTube. She's creating some really great videos on there. And last of all, a big thank you to our speakers, Dr. Steph Eakins and Dr. Zirva Khan, who are joining us to give the morning talks. And Kat's going to introduce them a little bit more in a second.
Thank you. So just in terms of what we offer at Medapply, we have one-to-one tuition, which is our most personalized service. This is where you'll be able to go through any sort of queries that you may have and kind of learn the content of the UCAT, BMAT, personal statements, and interviews. We also have cohort teaching, which is a new thing that we're looking to introduce for the UCAT season this year. So this is where you'll be able to join a group of up to 20 students and have weekly sessions covering the UCAT, BMAT, etc., with one or two of our expert tutors. So please do keep an eye out for those. We're really excited for that to launch. We also offer many one-day events like this one, and we also have a forum and online resources. So today at the end of the event, we'll be having a Q&A, but if we can't get around to answering your question, please do post them on our free online forum, and one of our lovely tutors will get back to you as soon as possible. We also host free webinars, which we're looking to do later on in the application cycle, focused on specific parts of the application process. So we're going to start with Dr. Zirva. So just to introduce her quickly, Dr. Zirva is a GP in the West Midlands and qualified as a doctor over 8 years ago. Her main interests include widening participation, mental health, and health education. She's qualified in sexual and reproductive health and medical education. So thank you so much for joining us.
Thank you very much for the lovely introduction. I hope everyone can hear me. It's always difficult to tell on this side that whether they can or not. So thank you everybody for joining. It sounds like there's a really exciting day ahead. I'm just going to try and share my screen. Okay, I think we can see my screen. Okay. So like Catherine mentioned, I'm Zirva, I'm a GP in the West Midlands. Thank you guys for asking me to talk about general practice today. I hope it will be insightful for you. As a general rule, I want it to be interactive. So if you can, write in the chat. I don't think I necessarily can see what's going on in the chat, but it would be nice to know that you're interacting as well with some of the scenarios that I will discuss. So yeah. The things I'm aiming to cover, I won't spend too much time talking about myself, but I'll talk a little bit about what general practice is, because I don't think everybody actually has a good understanding of what it is, why I ended up becoming a GP, kind of my typical morning, and advice onwards. And I'm happy to take some questions at the end as well. So I'm Zirva. I'm I would like to say a fairly regular person that always wanted to do medicine. I went to a state school where the average kind of A to C was about 30%. I think there might have been one other doctor in the whole school in like the 5 years before me. So there weren't many people that would go on to do medicine from there. But I really wanted to pursue it, and I was supported in it as well. I didn't really have any mentors or anything like that. So I think students nowadays are so much kind of luckier in terms of the kind of help and access they have to, you know, even just advice about applying and personal statements and work experience. So I probably sound really old, although for me 2005 doesn't seem like that long ago, but I did my GCSEs in 2005, and then I did my A-levels in 2007. I did work experience between that time, and the only work experience I got was like in a hospital where I helped out on an elderly care ward. It was really good though, because I got to kind of work with healthcare assistants, nurses, and doctors as well. And by the end, I was actually able to come in and watch a surgery, which was like really cool for me then. I did apply for medicine in my last year of A-levels. So similar to what you'll be doing from summer onwards, you know, really kind of sitting down, getting my personal statement right. UK CAT was introduced the year that I applied for medicine. And then I applied to four places, sorry. I only got one interview and one offer, which was University of Liverpool. So I didn't take any breaks. I didn't take a gap year or anything. I managed to get the A-level requirements that they wanted. And I went on to do the 5-year course, which I really enjoyed. And it wasn't my top kind of uni choice, but to be honest, it doesn't really make a difference because I enjoyed it in the end and I got the experience that I wanted. I am originally from Manchester, so I really wanted to go back to Manchester and work there. And as you can see, like I had a real kind of variety of what jobs I did. So I'll kind of break it down because it might seem like jargon to you, but I did orthopedics, which is like bone surgeons, gastroenterology, which is all about kind of the stomach and the gut, general surgery, which is like surgery of that area, worked in A&E, worked in general practice, and then I worked in respiratory medicine, so all about lung problems. And then in that last year, so where it says A&E, GP, and respiratory medicine, I then had to decide what I wanted to do next. So whether I wanted to take some time out or whether I wanted to go and become a specialist in anything. And I don't know why. I think I just felt like I just want to get on with it, get my specialism done. And then at least I'm done. Like I've done everything that I need to do. So I applied for GP training in North Staffordshire, which is in the north part of the West Midlands. And I started that in 2014. So I qualified about a year ago. 2 years ago. Yeah, so I guess question a lot of people have is what is general practice? So everyone has a registered GP. Everyone should have a registered GP anyway. And they're known as like the gatekeepers of the NHS, because essentially if you need anything, if you have any sort of health problem, and you're not like really sick and really unwell, you would probably go to the GP to ask them about your health problems, whether it's something really minor or whether it's something, you know, maybe a bit more serious. So we deal with at least 90% of the population, majority of the time. The 10% are the people that need to be in hospital, they've got cancers, or they need to have operations, or they're too sick to be kind of managed at home. There are thousands of GP surgeries across the country, and internationally, people would know a kind of a general practitioner as a family doctor. So we are kind of consultants in family medicine. I don't know whether you guys have worked, when you guys have been to GP surgeries, have you always seen GPs or not? But certainly where I work, there's lots of different types of people that work with GPs. So I would be the kind of consultant, so to speak, but then I also have doctors who are fully qualified, but they're not GPs yet, so GP trainees. We also have foundation trainee doctors, so, you know, in their first couple of years of qualifying. We have nurses, advanced nurse practitioners, pharmacists. We have obviously the reception staff, the secretaries. We have lots of people that work with us, and we very much rely on each other to be able to function, because I think alone as a doctor, I don't think I'd be able to manage a whole surgery setup by myself. So I'm very much indebted to the people that I work with. So why did I choose GP? I mean, you saw from my jobs that I did in the early part of my career, I chose like a bit of everything. To be honest, I didn't actually know what I wanted to do. I used to think I wanted to be a surgeon when I first started medicine. And then I thought, okay, I want to do something, you know, really fast paced, like A&E, really sick people coming and, you know, do this and that. And I could save people's lives and all of this. But then when I had all of that experience from my first couple of years, I just didn't want to work in hospital. There was nothing in hospital that really attracted me, which is ironic because as a medical student, I really didn't like general practice. I thought it was really boring. So those training experiences during my foundation training, some people said that it was a bit late for me to choose that, but to be honest, like, I know there were some medical students that knew exactly what they wanted to do before, but I just didn't. And I don't think I lost out because I didn't. It started to dawn on me that, like, you know, the work-life balance I had as a foundation trainee, I didn't want to have that forever. I could maybe do that for the next kind of 3 or 4 years, but then after that, you know, I was single before, so I had, you know, the world was my oyster. I could do exactly what I wanted without, you know, having to worry about anybody else. But now I was settling down. I was wanting to try and, you know, there was other things in life that I was actually enjoying more than just being a doctor. And like I said, like, I just could not pinpoint on any particular specialty that I really, really liked. So I was lucky when I did general practice in my foundation training years, I actually really enjoyed it. The stuff that I thought I hated as a medical student, I really enjoyed. So yeah, I decided, okay, let's just give it a go and apply for GP. And I did, and I got in. The first year and a half, I again rotated around jobs that I had never done before. So I did elderly medicine, I did obs and gynae, and I did sexual health. And they were actually really useful for me because as a female GP, you can imagine pretty much any female would much rather come and see a female GP than they would come and see a male GP because of the things that they like to talk about. So I feel like I got really good experience from that. So I'll cut kind of my story now. Let's talk about what I actually see and do. So a typical day in my surgery has changed a lot since COVID. And what I want you to do whilst I'm doing my slideshow and talking about different things is I want you to really kind of pay attention to the changes and reflect on the specific cases that we talk about, because these are the things that will matter for you in your personal statements, and these are the things that will matter for you in interviews as well. It's not just kind of what you see, it's kind of behind that, the effect of these sort of things. That's what's happening, what you see, and the effect of that. I don't know if that makes any sense, but so normally I get in before 9 in the morning. Depending on how much admin was left over the night before, I might come in a bit earlier. My clinic normally starts at 9. Pre-COVID, I would have just done face-to-faces constantly between then and probably about midday. But now, because of COVID restrictions, we have changed the way that we're working a lot. So we're doing video consultations, telephone consultations, and very few face-to-faces. It has meant that we are more accessible for people, for example, working people that aren't able to take days off. But equally, it means that there are a group of people that probably don't find us as accessible anymore. And that's, you know, I want you to think about who those people could be. And I'll come back to that at the end of the slide. So I do that till midday. So it's full on, you know, probably about 14 to 15 consultations in the morning. And then I have a little window. Sometimes that window is shorter depending on how busy the morning was, where I can just catch up on admin referrals. If I need to do any home visits, I do that. You know, there will have been some urgent extras or calls. And then I might have a little bit of time to have a bit of a break. And then, to be honest, it all starts again very quickly at 2. Usually I'd like to say that it goes on till 5, but often it goes on till later. And again, video, telephone, very few face-to-faces. And then the rest of it all, admin, urgents. And I really try to leave on time, but to be honest, especially since COVID has started, we're not leaving on time. And if you can imagine that, that's a really, really full day, a day of like every single patient has a different problem, a different thing you need to be switched on for and sort out. So fairly heavy. So I wonder if you've had a bit of a chance to think about the change in the way that we're consulting now and the people that might be disadvantaged because of that. So I can't see the chats. Oh, hold on. Let me see if I can bring the chat up. Yeah, older people, definitely. People that can't access technology. You know, there's people that are poor, people that are cared for. So yeah, you guys have it completely right. You know, homeless people, definitely. One of the biggest problems I have with homeless people is that they have pay-as-you-go phones and they don't always have signal. They're not able to charge their phones. And, you know, these are the people that are actually more poorly people generally, which is sad. But that's why we have the face-to-face capacity as well, so we can accommodate for those people and home visits as well. So aside from my regular work, which I do half the week, I do quite a lot of other things as well, which take up, you know, it's like an hour here or there, but then it does add up. So I never thought 2 years into being a GP, I'd be doing all of these sorts of things. But I guess as you qualify, you start kind of developing some sort of interests. And one of the things I've always been passionate about is kind of medical education. So I actually work for the Royal College of GPs, and I arrange events for GPs across the West Midlands. I've done my teaching qualification at Keele, so I can teach medical students, and I do that ad hoc. And I've also done some other work with Keele. I work for Luma Medical. I've done lots of outreach activities. So that means kind of connecting with minority communities in my local area of kind of Stoke-on-Trent with the radio. So we've done lots of interviews with them. And I also write, and I quite enjoy writing. So if you would have asked me as a medical student, or even before I applied into medicine, would I have saw myself doing these things? I probably would have been like, you're joking. Like, that's not something, you know, that's not something you do until you're like 10 or 15 years qualified. But I've been really lucky that the interest in the things that I've done as a student and after I qualified, I've just kind of found myself in these, which is, I think it gives me kind of more of a holistic approach to what I do. And also as a practicing GP, I can take a lot to these avenues as well. Okay, so my week is actually quite busy. And you can see a lot of mom being mom. That for me, I take a lot of pride in that, because, you know, my son deserves me as well. But as you can imagine, like when you're being mom all week, obviously your mom, whether you're working or not, and you're also trying to balance everything else, it can be quite interesting. So I suppose what I'm trying to illustrate is being a GP is not just being in a surgery. You can be lots of things and be a GP as well. And lots of hospital specialities are allowing that flexibility too. So it's good to be aware that specialities are flexible. You know, there's lots of people who might want to apply to medicine that are already parents. They've already got other commitments. They might be carers. They might have other duties. And actually, it is possible to be a doctor, be all of those things, and actually be a specialist and be all of those things. And because what you bring to your work is all about the experience and the life experience you have as well, I think, anyway. So I know lots of people are asking questions. I think it'll be easier for me to answer those questions at the end of my slideshow, just because I know that there is a bit of a time restriction. So now I'm going to talk to you about just a real kind of snippet of a morning clinic that I have. Okay, these are all, you know, cases that have been anonymized, and for obviously confidentiality purposes and things. So confidentiality is something that you guys need to know about if you don't know about it yet. I'm sure the Medapply team will be covering that at some point. So I had a telephone consultation with a 75-year-old male. He tells me he's had a history of a cough for about 6 weeks. He thought it started off as a cold, but he got better from the cold, but the cough went on. And I asked a few more questions, and you know, with a cough that's going on that long, you want to make sure there's no other serious things. He doesn't smoke, not coughing up anything like blood, and he's already had 2 courses of antibiotics when he spoke to other doctors. He's not got any other serious kind of features, but he's just very tired. So for whatever reason, there was something about this that just wasn't fitting. Like, you know, I just wasn't comfortable with it. So I wanted to see him, and I wanted to listen to his chest. So I brought him in. And it wasn't very exciting, you know, it sounded fine and his throat was fine as well. So we said, okay, because of your age and the fact that your symptoms have gone on for so long, let's do some investigations and see what is going on. So I arranged an urgent chest x-ray. Some might say, okay, why would you arrange like an urgent chest x-ray? But, you know, there are things about him that even though a lot of it sounds okay, but his age, the fact that his cough's gone on for so long, he's already had 2 courses of antibiotics and it's not settled down. We know that this could potentially be a cancer. And unfortunately, it was a cancer. So when we got that x-ray result back, we have to sit down and we have to have that conversation about the fact that, you know, he already had the warning shot when he came in, because he knew that the reason why we were doing it so urgently is we wanted to rule out something serious. And he was really upset because, you know, he's a grandparent, he's got a family that rely on him. But equally, when we talked about the kind of pros and cons, you know, that we have a 2-week wait system, so we can refer people really quickly to be seen by a specialist and have further scans done. And he more than happily took it, because what we know about cancer is the quicker you pick it up, the quicker you treat it, the more likely you are to be able to survive that as well. So that was the start of it. Then next, I have a call coming. Dr. Khan, there's a paramedic on the phone that they really want to talk to a GP. Any chance you could pick it up? Don't like my clinic being interrupted, but to be honest, I don't get calls from paramedics every day either. So, okay, I said, yeah, sure. Before I pick up my next phone call, I'll talk to the paramedic. Paramedic went out to see 85-year-old female. You know, she's housebound. She's got dementia. She's got carers. They were concerned that one of her legs was really swollen and red. She had a temperature, but she was otherwise okay in herself. And they did loads of observations, and otherwise she was okay. They didn't think there was anything serious going on, but equally, they didn't think that she should be going to hospital, because remember, with COVID, hospitals are a lot busier. Someone like her could pick up an infection if she goes into hospital. You know, they're more vulnerable people. So we were kind of torn. What do we do? Do we send her to hospital to get treated because she is bedbound, she has the potential to become sick really quickly, or do we treat her at home? So then what we decided to do was, in conjunction with the carers, we made a bit of a plan. We're going to keep her at home with antibiotics. They're going to, you know, she's got carers coming in 4 or 5 times a day. And we also have something called hospital at home. So these are nurses that work in the community that will come out and monitor her over the next 24 to 48 hours. And if she does deteriorate, so she does start to become more unwell, she starts to show any signs of sepsis, then we have a way of getting her into hospital without her having to call the paramedics out again or calling the GP. So it's just more streamlined. So, okay, that took about 15-20 minutes, but we got there in the end. And then I guess switch back on to the next one. So my next telephone consultation was with a mum of a 2-month-old baby. Baby's been fine so far, no problems with her development, growing, etc. But she's had a fever, and she's not drinking her milk, she's not really weeing, and she seems really tired. So this is like ringing alarm bells for me. So I said, let's go on video so I can see you quickly. Mum was pretty swift on her phone. So I saw her on video and she just looked limp. She looked I was really concerned. And I thought, do you know what? If I bring her in, I'm just going to be delaying time. Me bringing her in and assessing her is probably not going to change anything. She's 2 months old. 2-month-old baby should not have a fever. And equally, if they are a little bit poorly, they usually still drink quite a bit of their milk, and they will wee as well. So I was really concerned. And to be honest, all I could do was call the ambulance. That's the best I could do. If I did anything else, I'd be delaying time. Mum was obviously quite scared and upset and things, but thankfully, ambulance came really quickly, took her in. The pediatricians in the hospital were kind of really swift and managed to rehydrate her. They found that she had a kind of a urine infection. She got better really quickly and came home, and she's been fine since. So, you know, what we know about infections in young children is if we don't deal with them quickly, they become sick quite quickly as well. And with someone that small, you just don't want to take the risk. It's better that they go into hospital, even if it's just for a bit of monitoring and reassurance for the parent as well. At the end of the day, it's the parent that's living with the child that's sick. Okay, so I've just literally put my phone down, and then my door knocks, and I'm like, oh man, I've not even had my glass of water yet. All right, come in, what's going on? Okay, so like I said, we've got other people that work with us. So healthcare assistants are super helpful at doing things like ECGs, which is basically a heart trace. She was asked to do a heart trace for a patient who spoke to a doctor on another site. So I work in a group of 6 sites. And basically the background about this patient is she's 50. She's known to have high blood pressure, but she was having headaches. And so the doctor was concerned that maybe there's a problem with the blood pressure, and actually she needs to, come in and have kind of an urgent assessment by us. Because sometimes headaches are really vague. Headaches can be something really minor and they could be something really serious. And you don't know until you actually bring them in what's going on. So I had the heart trace, which she had ready, but I was more concerned because she's got such a high blood pressure. So I'm not going to go into the details of what blood pressure is and things, but most people's blood pressure should be under 140/85. And 220/130, that in itself is ringing alarm bells. So I was like freaking out. I was like, oh my God, I can't believe this person is here. Quickly, quickly, show me the ECG. And I see this, which I'm not going to lie, I don't look at ECGs very often. Okay, I'm not in hospital as much anymore. So it's not really something I have, like, I'm not as slick as anymore. But there were just some squiggles on here that I was not happy with. And I quickly phoned up one of my friends on another site and I sent a picture and I was like, look at this, what do you think of this? And we were like, 999. So I'm telling you, the ambulance people knew my name that day because that was the second one I was sending in. But to be honest, you know, the risk we have is if that blood pressure stays as high as it was, they could have a heart attack, they could have a stroke. And these things are time dependent. Their heart is showing difficulty because of that high blood pressure. If I leave it even a couple of hours longer, they could drop dead. I don't know. I don't want to take that risk anyway. So the safest thing to do is have them get picked up by an ambulance and taken into hospital. So feeling a bit overwhelmed now. You know, it's been a busy morning. You know, this isn't what a lot of people think general practice is like, but it was pretty full on. But again, switch off, switch back on again. So 45-year-old female, we had a video consultation this time. So she's concerned that her skin and her nails on her feet just don't quite look nice. She doesn't like them. She just doesn't have any symptoms by them. Just don't like them, doc. Don't like the way they look. And I was like, all right, okay. What don't you like about the way that they look? That. All right, okay. So here we're dealing with something that's very benign. It's actually just aesthetically more of a problem. So, you know, isn't giving us symptoms, which is good, but most definitely looks like fungal toenails. Now, most people think that this is the bread and butter of what we see. So we do see a lot of problems like fungal nail infections or skin problems and things, but actually it's just all mixed in with everything else. And she wanted to have some kind of magic pills to fix it, but we can't give magic pills to fix it because we need to know exactly what's growing under those nails. So what did we do? We asked her for some nail samples that we sent to the lab to find out exactly what fungus is growing so we can give the right treatment for her. A lot of people think treatment's like really straightforward, you just have some pills, sort it out, but those pills actually have side effects on the liver, so we need to do lots of monitoring, make sure all of that plan is in place. And yeah, that's what we ended up doing, and she was happy because she had beautiful nails after that. And then I was like, okay, when am I going to have a bit of a breather? So I then pick up the phone. I said, I'll do this one, and then I'm going to go, you know, have like a 2-minute break just to kind of chill a little bit because it can get a little bit overwhelming. So spoke to a 24-year-old female. She recently lost a job. A relationship ended a few years ago. She's got symptoms of anxiety and depression, and she was basically wanting to try and get some help. So here, this is where I want a little bit of interaction. So what can you know, what might be, looking at the kind of situation we're in with COVID, why might a 24-year-old female in this current climate develop symptoms of anxiety and depression? So, you know, I've already given you a few hints. So she's lost a job because of COVID. She's got relationship problems. So her relationship, long-term relationship, ended a couple of years ago. What else do you think could be contributing to the fact that she now has symptoms of anxiety and depression? I mean, in the end, we had like a dual approach anyway. So we decided to talk about medication, but in the end, we decided not to go for it because actually what she needed more was psychological support. So signposted her to the local psychological services and she got some help through them. So let's see on the chat what people are writing down. Yeah. Guys, you guys have it on it. You know about these things. Well done. Okay. So yeah, lack of communication, lack of support, you know, being a single, you know, she could be a single parent with children, lots of stress, financially, yes. Not being able to see your friends, worrying about having a job, obviously, I don't know what that relationship was. We didn't get around to discussing the details of that relationship, but it might have been something that was something that she still has grievances about. She's young. Yeah, this is all good. Just looking here. Yeah, well done, guys. Okay, moving on to the next slide. Okay, and so that was just literally a little snippet of my morning. And the rest of the day was more mental health. We're seeing so much mental health at the moment. Women's health, menopause, joint pain, skin rashes, male problems, everything, you name it, any speciality of any problem, it all comes to us, which is, for me, exciting. I like not knowing what I've got next, and I just deal with it from scratch. But equally, I can see why people don't like to have that much variety, because they don't feel like they can keep up. And how do you know a little bit about everything? You know, how do you know whether you know enough or not? So I hope that was useful for you, to see kind of a snippet of some cases that we see in general practice. And like I said, I'm sure you're probably surprised about the variety that we do see. So yeah, medicine is a specialty full of specialities, and I think people forget that. I think from this point onwards, what would be good is the stuff that we're talking about today, kind of look into it a little bit beyond just the cases from what you see. So even that fungal toenail, you know, on one hand, you'd be like, okay, why is she bothered about something that's not actually causing her any symptoms? But if, for example, you know, her job means that her feet have to be out, or she had fungal nail infections in her hands, and she was working as a care worker, she'd be quite self-conscious that everybody can see her nails. I remember a case where there was a actor who had acne, and the doctor looked at the acne, and they were like, the acne is very mild, why are you worried about the acne? And he said, well, my job relies on the way that I look. So, you know, we don't just see the kind of problem the patient has, we see the problems behind that as well, and how it affects their life. It's really important that you get as much work experience as possible. As Shrey said, it's very difficult at the moment to get it face to face, but especially in the last year or so, people have really stepped up in what kind of virtual work experiences there are. So just honestly, sign up everywhere. There's loads of free work experiences going on. I don't think they've really started yet, but they will be starting soon. And just talk to people, you know, connect with people. You're all on social media. You know, if you want to ask questions, if you want to learn more about medicine as a specialty overall, or any specific specialty, just ask questions. Most of us are happy to be approached. As you can see down at the bottom, I am on social media, and I get approached quite a lot about things. I talk a lot about kind of getting into medicine and stuff, and I'm more than happy to be approached afterwards as well. And most importantly, you know, you may well get an interview, you may well get an offer, but also part of that is getting your grades as well. So I have full sympathy with everybody who's in kind of schools, in education and stuff at the moment, because I don't know how I would have coped with all the stresses that you guys have had, honestly. You know, you don't know when you're going back in, you don't know when you're going to teaching, you know, like how virtual learning is really difficult, but fingers crossed, I've got lots of faith in you guys to do well. So yeah, and that's my son when he was really little. I still look back at the photographs, and yeah, thanks for listening.